see. Horizontal bolster, I feel this is the best way because you can see the back is straight. You can see the back is straight and it gives a counter pressure for the when you are putting the needle in. So this will help you in holding and stabilizing the kidney. This is the way some people use. So it is hanging like this. Kidneys also hang down. The track is more longer, and there is a more mobility of the kidney. So it will not stabilize. But anyway, some people do it like that, and they are very happy. There was a study about the putting of bolsters, and statistically there is no difference whether you put the bolsters this way or that way, depending upon the length of the track. But other lengths, they say there was difference. Anyway, there is another way by Swinlahame. Why are we putting bolsters? So that abdomen is free, patient is able to breathe well. That is what is our concept. Our anesthetists, they don't allow us to put the bolster in between. But Swinlahame puts it like this. And he inflates it. He says when there is a good bolster support, the kidneys are stabilized, they come posterior and puncture becomes easier. Studies have shown there is no difference whether it is a vertical bolster, horizontal bolster, below the abdomen or no bolster. All is same. This is the adjustment between you and your anesthetist. Positioning of monitor should be very comfortable. They should be straight in front. If the patient is lying like this, head is on this side. If I have to do the inferior calyceal puncture, I should put both bolsters or both monitors on this side. If I have to go superior calyceal puncture, both monitors should be on this side of this here. So that everything is in front, I should not be working like this all the way. Otherwise neck starts paining, you should be comfortable. So this is the way how you should position the bolsters. Both the bolsters on this side of Siam or that side of Siam, depending upon your alignment. Coming to positioning of Siam. Right from morning, you are getting confused. Whether to put it 0 degree in the beginning or 30 degree in the beginning. I tell you my concept. You agree or not? This is the position how the kidneys are. Angled at 30 degree. You will agree to that. This is the supine patient. Now the patient has been turned prone. And which are your target? Your target is either the posterior calyx or the anterior calyx. Right? Once you know your target, you have to make either the posterior calyceal puncture or anterior calyceal puncture. You should see your target right in front. You should not see from the side. And if you have to see a target right from in front, you have to turn the Siam 30 degree towards you. So that if this is the kidney seeing you, you should be seeing it like this, on the face. Therefore, my concept is to start puncture with the Siam 30 degree tilt towards you. Another advantage is the Siam, the X-ray tube goes away from your body, so your fertility is maintained. Remember that. But for supine PCNL, it should be in a different way. This is how you do it in prone, but in supine, it will come closer to you. Not only that, that makes a difference. If you are puncturing the kidney in 0 degree position, you will be puncturing through the red arrow. If you are puncturing through the 30 degree, you will be puncturing through the blue arrow. And this 1 to 2 centimeter migration of puncture on the renal parenchyma will result in a great difference in the bleeding complication. If you are puncturing the medial portion of the kidney, it is going to bleed more. If you are puncturing the lateral portion of the kidney, it is going to bleed less. Because the renal vasculature, when it comes inside, it divides into anterior and posterior branch. Further, they go on branching, and ultimately there is a arcuate artery all around. And if you puncture the central portion of these arcuate arteries, it is going to bleed more. While all horizontally oriented or vertically oriented vessels, if you are coming in between that, through the convex border of the kidney, through the broader spike line, it is going to bleed less. If you puncture the center portion, it is going to bleed more. So I strongly recommend you should see the target right on the face and position the Siam with 30-degree tilt towards you in the beginning. You have positioned the C arm. Now what do you see with C arm? What does it show? C arm, one view is like seeing through one eye. Is it sufficient? If I close my one eye, I can see all of you. But is it okay? Or it is like taking a picture with a camera. We feel we are seeing everything. Is that enough? No. It gives you only the length and breadth. It does not give you the depth perception, the distance. This is a camera picture. If you see with one eye, you will see this. You will see the moon in the cart. You will see the moon hanging with the crane. You will not appreciate the enormous amount of distance between the moon and the cart if you are seeing only with one eye. If you want to experiment, when you are driving a car, suddenly close your one eye. You will not appreciate the distance between your car and the car ahead. You will immediately open up so that you know the distance. Experiment it and see it. What happens if you are seeing with one eye, like in this case, whatever object comes on this line, will be seen as if you have reached at the carpet. You have been seeing it right from morning. When you place the needle onto the skin surface, you are feeling that it is in this. So on this line, whether the needle is at the skin, at the target, or deeper to the target, all these three in one C-arm view will be seen like this. This we have seen, you agree? You don't know the depth, and therefore God has given us two eyes, and with simultaneously with both eyes when we see, we come to know all the three dimensions. Now if I have only one eye, and I have to see the distance of myself between Umesh Sharma, I will go to that side with the same and see from here. So I have to see Umesh Sharma through two angles. That is what, if you have to do a depth perception, you should do. So you change from 30 degree to 0 degree. When you change from 30 to 0, whatever needle tip will be there on this line will be seen at the target. Others will not be seen at the target. Only the yellow needle, oh sorry. My God, I jumped a lot. Yeah. Only the yellow needle, which is seen at the target in picture number 1, in 30 degree alignment of the C-arm, if you turn from 30 to 0, it is the only yellow one which will remain at the target. But what will happen to the other one? Very sincerely now you see that what will happen to the other one. The other one which was seen at this target in 30 degree, in 0 degree view, it will be lateral to the target. Am I clear? In this C-arm 0 degree view, sorry. In the 0 degree view, if it moves lateral to the target, I am superficial, I am behind the kid. The other way, if I turn from 30 to 0 and the needle which was seen in film 1 at the target, this one, when I turn from 30 to 0, it will move medial to the target in the next view. This is the crux of pcnl. If you understand that, puncture becomes very easy. Don't get confused with caudal, cephalad, right, left, all sides. If I have to see this, I can see this way, that way, I can peep from above, I can peep from below, caudal, cephalad, everything is possible. I have to just obtain a second view. Remember, only one view. 30 at 0. In 30 to 0, if it moves lateral to the target, it is superficial. If it moves medial to the target, it has gone deep. This is the concept. Now puncturing techniques. What are the different puncturing techniques? There are three: Bullseye technique, Triangulation technique, and Gradual descent technique. Bullseye technique is very simple. Bullseye is just seeing in the center and going and hitting it at the target. So in bullseye, when you position the C-arm at 0 degrees, you have to just maintain the needle tip, needle hub in the same straight line. Go straight, 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 you will hit the target. You will definitely hit the target if you are able to maintain needle tip, needle hub in the same straight line, in the same alignment. At one go, you will definitely hit the target. You will not realize, you may go even beyond, but your image will remain at the target, right from here to there. This is the sure shot technique called bullseye technique. It can be done in 0 degree, it can be done in 30 degree, wherever you want. Only thing, you have to maintain needle tip, needle hub in the same straight line, go in and you will be at the target. See, you have to maintain this needle tip, needle hub in the same straight line, go in deep, 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 you will reach at the target. And our target is a calyx, because we are entering through the calyx. And stone is in the pelvis. You reach to the calyx vertically down like this, and pelvis is here. After that, you have to turn and go inside. Am I clear on that point? So bullseye technique with C-arm in 0 degree position, disadvantage is the track so made has a vertical segment. It is medial, it has a vertical segment from skin up to the calyx, and then inside the kidney you have to manipulate, wriggle out, reach up to the stone in the renal pelvis. When you are doing that and you have made a straight track, and now you are trying to turn the position. Where is the fulcrum? Fulcrum is at the renal parenchyma. When you are doing vertical entry and then making it horizontal, it is at the renal parenchyma and it is going to bleed more. Also, bullseye technique, you are puncturing the central portion, the medial portion of the kidney, which is going to bleed more. Another disadvantage is, it is a good advantage, it is a sure shot technique. It is medial puncture far away from the column, but disadvantages are medial puncture away from the Brodell's line, it is going to bleed more. If you enter vertically and the guide wire has to go horizontally through the infundibulum, you need a Terumo guide wire, which will find its paths. Therefore, people with difficult punctures, they will always be using Terumo guide wires. Otherwise, if you are going in the same straight way, even your J-tip will straight away walk in. So difficult guide wire placements, particularly if you have punctured the anterior calyx. Tearing of renal parenchyma when you are doing this maneuverability inside, and mobility within pelvic initial system, because vertical track and horizontal movements. Your difficult movement is there all. Coming to triangulation technique, I will explain this. In triangulation technique, so please, whosoever is sleeping, this will make you clear what is triangulation technique. First, position the C-arm in 0 degree. Identify the target. This is the target, and make a mark A. Here is the target. Now change the C-arm from 0 to 30 degree, and now when you see this particular calyx, it will be marked here as B. Now you have 2 points in 0 degree A and in 30 degree B. Actually, if you see mathematically or trigonometrically, you have created a right angle triangle on the back of the patient. Why right angle triangle? This is a 90 degree angle if the patient's back is straight, इसमें light नहीं जलती. Where should I go? I'll come here. No, it's okay. This is A to B is a straight line and A to C is a right angle triangle. And since you have turned from A to B, making an angle of 30 degree, this angle C is a 30-degree angle. So this is a right angle triangle on the back of the patient. One angle 90 degree, another angle 30 degree. Obviously the third angle has to be 60 degree because the total of these three is 180 degrees. And in this, if you have all the three angles known to you and one length you know, A to B you can measure on the skin. In a triangle, if you know all the three angles and it is a 90-degree angle, 90-degree triangle, the Pythagoras theorem applies to this, and that says you have created a right angle triangle 90, 30, 60. We know all the three angles and length of one arm. So length of the other two arms very easily can be calculated. And to put it simply, I will not take you to mathematics. Arm AC means from 0 degree if you go in, it will be 1.73 times the arm AB. AB you know. And if you want to start from C and go in, sorry, B, BC will be just double the AB. So it has become very clear. You have marked A, you have marked B, measure the distance between A and B, and now position the C arm in B position, means in 30-degree position. Start from there, take a bullseye puncture, and you already know the distance between AB was 3 centimeter. So if you go 6 centimeter, just double the distance, you will reach at the target. So it is such a easy, nicely trigonometrically calculated distance. You know, you have to start the bullseye puncture at point B, C arm in 30 degrees, and you know if the distance was 3 centimeter, you have to just go 6 centimeter and you will hit the target. So this triangulation technique has made the life simple if you are fond of doing bullseye punches. I hope this is clear, or any, because triangulation technique, everybody has his own ideas, but this I have made it very simple to understand. Coming to the gradual descent technique. Gradual descent technique is gradually you are descending down onto that particular calyx you have chosen. So it is like a plane landing onto the runway. It is always done with the C arm in 30 degrees, as you see in the first picture. And when you start, you don't start at the calyx. You take a distance of 3 to 4 centimeters depending upon your landing distance from skin to the calyx. If you feel it is going to be 4 centimeters, go 4 centimeters away and then start landing into that descending down onto that. So 3 to 4 centimeters lateral, you position the needle like this in the second picture. And it should be in alignment with the infundibulum so that your track is straight. When the plane lands, it should go straight onto the runway. There should not be any angulation. And when you do that way, you can straightway go inside and it will be in alignment through the convex border of the kidney and it will be less bleeding. So gradual descent technique, you start 3 to 4 centimeters lateral, go into the cup of the calyx, you will be coursing through the convex border of the kidney and you will reach into the kidney through the Broddel's white line. And remember, in the first image which you will take, when your needle has gone in, there is a possibility that your needle has gone straight at this. There is a possibility your needle is here. There is a possibility your needle tip is here. And in all the three, you will be feeling that we have reached at the tip. We have reached at the target. Now what you do? Just turn from 30 to 0, and when you turn from 30 to 0, in the 0 image, If your this goes laterally, the needle which was seen at the target, if that moves laterally, you are superficial. If you are superficial, you have to remove the needle, increase the angle and go in again. If it moves medially, means you have already gone deep, remove your needle, decrease the angle and go in again. Now I will show you some real pictures. This is Siam is being positioned from 30 to 0 degree, and see what is happening. The needle is moving. Come on.
Medially.
Medial to the target. So it has gone deeper to the target. What I have to do, it has gone deeper. I have to pull it out, decrease the angle and go in again. And the distance, if I have moved so much laterally, my mistake is too much. If I have moved just a little bit, I will decrease little bit. If there is a lot of distance, means I have to reduce the angle tremendously. Now see what is happening. The Siam is turning from 30 degree to 0 degree, and needle is moving lateral to the target. So it means I am superficial. This was on the skin surface. Therefore, there is so much of distance. And when the Siam is moving 30 to 0 and your needle tip remains exactly at the same place in the cup of the calyx, you are exactly there where you want to. Just go to 4 millimeter in and you are inside. So gradual descent technique is lateral puncture through Broddel's line, easy guide wire placement, minimum bleeding, offers excellent mobility because you have gone straight in, straight out, and there is a excellent mobility. There is no bleeding, so vision is clear. You can do a better job comfortably. So in nutshell, there are 3 ways. This is bullseye 0 degree. This is bullseye 30 degrees. And this one is gradual descent technique through the convex border of the kidney in alignment with the infundibulum going right up to the renal pelvis. This is my concept. Coming to dilatation of the tract. Any questions in this? Yes. Only thing is in superior calyx, if it has gone quite suprafascial, you cannot go above 10th rib. So then you will have to do bullseye. So you have to make adjustments in that. Yeah, Thanos. If your needle tip is at the target in 0 degree and 30 degree, you are at the target. There are 3 situations when water will not come. Either there is a blockage between the PUJ up to the stone is blocking, your water is not reaching up to that. There may be some pus in this, which is thick pus, which will not allow the fluids to come out because needle is thin. Sometimes there is matrix all around the stone. It will not come out. If you have made multiple punctures, there will be blood clot around. Then it will not come out. So these are the 3-4 situations when you will not get a free flow outside, but you are at the target. Be confident. If 30-0 same place, no worries. Pass the guide wire, it will go in. You are in the PCS. So by PCNL, whosoever is doing, he is not following this technique. They are doing all in 0 degrees. They are not doing the identity, means exact anatomical way of doing PCNL is this, so that you know you are hitting at the target. Otherwise, you can hit the target like this and like this also, no problem.
exactly what Escapal sir told, gradual descent. We are following gradual ascent. Exactly gradual ascent. Your own technique we are following. We are very happy with it. Same cup of the helix, not here and there. Exactly at the same helix. We can function. Same your own technique. We are doing the opposite direction, like left hand and right hand.
Chandra, you are a young man, and if you are following exactly I say you have to put the C arm close to you.
In supine.
Remember that.
In supine, sir.
Yeah. In supine.
No, no,
In supine, exact angulation will be when the C arm comes to you.
We'll have a nice debate right now.
Allow me a comment, please, Dr. Pal.
When I have Dr. DPC from Muzaffarnagar, you may be superficial, but you may be anterior, you may be posterior. At the superficial plane, you may be caudal, you may be at the distinct foot end. How to differentiate that you are superficial, but you are anterior, or you are posterior, or you are
Sir, I will say to you separately, you have probably not
like that. If you
Yeah.
are deep, so we can be polar.
Your needle has to reach at the target in 30 degrees. After that, turn from 30 to 0. It was at the target in 30 degree. When you turn from 30 to 0, if it is moving laterally, you are superficial or posterior.
Okay.
That
But
is
how
the
to
crux
make
of it.
that you are caudal or you are distinct for the
No, if you are caudal, then even in 30, your needle will not be at the target. If you are a caudal, you are caudal in all the angles. Whether it is 30 or 0, you will remain caudal.
But we have to manipulate the needle.
No, then you have to come out and hit the target. Basically.
Allow me a moment.
Yeah. Sir, please.
Yes, there is no need to do the bullseye technique at 0 degree, only to put the CBAR needle and opacify the system. Always do it on 30 degree. And a question, we operate very frequently patients that have been operated by other colleagues with open operation or other PCNL. Does this change your approach if the patient has been operated and there are scars and the position of the kidney, has it changed?
Any operated case, the kidney will be fixed posteriorly. It will not be so mobile. And then puncture, you have to remember that your angle will not be so deep. You have to go superficial. That is the only difference, and you may encounter some fibrosis on the way, so you should have a metallic dilators ready. They will be a little tough to dilate that area. These are the only two differences.
So then you go in another direction, not follow the previous pathway to get away with the scar?
But sometimes there is no other way. You have to go the same way because that is the most ideal way leading you to this goal. So you don't bother about whatever way you are going. If it is coming on the way, fibrotic material, you have to screw it more. Yeah.
गर्मी है तो बोला अपना
Microphone, please.
3 minutes.
हाँ वो
Yeah,
है
please.
वो लगा ये
That this technique is improvisation on the both techniques, both prayer techniques, that gradual descent technique. But when you are applying that gradual descent, how do you take that 3 to 4 centimeter distance, whether it is 3 centimeters or 4 centimeters or 5 centimeters? How do you decide that?
It is arbitrary. It is not that you have to exactly measure. You see the thickness of the patient and imagine the distance you have to travel from skin up to the waist.
It may not be exactly on the borderline.
No, no. It is not exact that it will be 3 centimeter only. In a female patient, anyway, I don't know whether, my one more talk is there. In that, I have shown how much distance to travel. There you will get the answer. There is one more talk.
In the triangulation technique, we take a right angle triangle, but it's not skin is not so smooth. It is not a flat surface. It is slightly curved.
Yes.
That end, whatever point is that 1 to 2 centimeters makes a lot of difference. I think whatever calculation we make on the triangulation technique are all good. That's what my opinion.
Absolutely correct. You have understood very rightly. We are only assuming that the back is 100% right angle. It is not that. Back is curved. So it is not exactly 6 centimeter. It may be if 3 centimeter